day, Marians. For today's lesson, I will be sharing with you one of the metabolic disorders known as Niemann-Pick diseases. In my presentation, we can see young ones as background and a quotation that says, "They only have a childhood to live a lifetime." You must be wondering why. It is because Niemann-Pick disease mostly affects young children and most probably newborn babies. So what exactly is Niemann-Pick and how does it affect a person's organ system? To explain the scenario, let us move to the next slide for a deeper understanding. Niemann-Pick disease is a group of inherited severe metabolic disorders that allows a certain kind of fat to accumulate in cells. The fat, sphingomyelin, accumulates in lysosomes, a membrane-bound organelles in cells. These lysosomes normally transport material through and out of the cell. It is an inherited neurodegenerative disorder due to the cell's inability to metabolize cholesterol. It involves the dysfunction metabolism of sphingolipids and sphingomyelin in lysosomes that result in accumulation of lysosomes, which affects 1 out of 150 births. Hence, it is rare. Niemann-Pick disease affects the nerves, the brain, spleen, liver and bone marrows. In addition, the severe form of the disease affects the lungs. People suffering from this condition often have symptoms associated with progressive functional loss in their brain and nerves and other essential body organs. The disease may take place at almost every age. However, it takes place mainly among children. So now that we have understood why young ones are mostly affected, because as mentioned, it is a hereditary disorder that are passed on to the next generation. And for in-depth explanation on how it is passed on, we have a presentation at the topic. However, let us first take a look back on the history of the disease. Historically, Niemann-Pick was discovered as a disease back in 1900s when a pediatrician noticed the child with an enlarged liver, enlarged spleen, and neurologic symptoms. In this case, the pediatrician took interest on the disease and started to study how did this disorder began. Thus the name Niemann-Pick, which was derived from two German pediatricians, Albert Niemann, the first doctor to identify the type A form of the disease in 1914, and Ludwig Pick, who first identified the type B form of the disease in 1927. Nonetheless, in the early 1980s, the term Niemann-Pick type 1 and Niemann-Pick type 2 were proposed to separate the high and low sphingomyelin forms of the disease. In 1961, however, Crocker proposed a classification of the disease that vary on the age of onset and severity. And this is how we have the types of Niemann-Pick, which was separated into 4 more categories. The first category is the type A, or the classic infantile form that appears during infancy, and is characterized by an enlarged liver and spleen, failure to gain weight and grow at expected rate, and progressive deterioration of the nervous system. The second is type B, or the visceral juvenile form, which usually present in mid-childhood and often have hepatosplenomegaly, recurrent lung infections, and a low number of platelets in the blood. The type C, or subacute juvenile form, and always fatal. However, life expectancy depends on when symptoms begin. If symptoms appear in infancy, the child isn't likely to live past the age of 5. And if symptoms appear after 5 years of age, the child is likely to live until about 20 years of age. It is the most common form of disease and a subtype with brain complication into C1 and C2. Last is type D, or the Nova Scotian type, which is a progressive neurodegenerative disorder characterized by the accumulation of tissue cholesterol and sphingomyelin. This disorder is relatively common in southwestern Nova Scotia because of a founder effect, thus the name Nova Scotia. However, it is no longer used. Type D is caused by the mutation in same genes as type C1 disease and was originally separated from type C to delineate patients sharing a common ancestry with otherwise identical disorders. Moving on for the prognosis. For type A, most cases with approximately 85% are being fatal by 18 months and the rest is from 2 to 3 years. In type B, the children may live a comparatively long time, but it requires supplemental oxygen because of lung impairment. For type C, as mentioned earlier, life expectancy varies. Some may die in childhood, while the less severe affected can live up to adulthood. The question now is, how does a person accumulate this disorder? Niemann-Pick disease is inherited with an autosomal recessive pattern. Accordingly, both alleles or copies belonging to the gene should be defective to cause the problem. Defective in this case indicates the alterations of genes to cause impairment in various body functions. In most of the cases, the parents of any child with autosomal type of recessive disorder form the carriers. They contain a single copy of the altered gene but remains unaffected, as the other copy causes enzyme productions. When both parents play the role of carriers, each pregnancy has about 25% chance to produce a Niemann-Pick affected child. Hence, doctors always recommend genetic testing and genetic counseling for family members who are probably the carriers of the fatal and recessive Niemann-Pick disease. And with the information given, we have now understood how this certain disorder merely affects the young generations and rarely being detected in adults. Above all, they only have a childhood to live a lifetime. But the next question now is, what are the symptoms and genetic causes of the said disease? Niemann-Pick disease types A and B arise due to mutations in the SMPD1 gene. This gene is required by the cells to produce an enzyme called acid sphingomyelinase, or ASM. Changes in the structure of this gene lead to deficiency of the enzymes. As a result of this, a fatty substance called sphingomyelin cannot be metabolized properly and is accumulated within the cells. This ultimately leads to cell death and a malfunction of major organ systems. Patients, however, with Niemann-Pick disease type C are known to share specific mutations in NPC1 and NPC2 genes. These mutations disrupt the body's cholesterol and glycolipid transport mechanisms, leading to the abnormal accumulation of these entities. So we have learned that Niemann-Pick disorders are characterized by the buildup of toxic amounts of fatty substances called lipids, specifically phospholipids and cholesterol, in various organs including the brain. Normally, specific enzymes in the body break down lipids, whereas people with Niemann-Pick disease either lack these enzymes or the enzymes do not function properly, causing lipids to accumulate within cells. And as the lipids build up in the cell compartment called the lysosomes, a larger group of diseases called lysosomal storage disorders emerge. For the pathophysiology, In the classic infantile type A variant, a missense mutation causes complete deficiency of sphingomyelinase. Sphingomyelin is a component of cell membrane including the organellar membrane, so the enzyme deficiency blocks degradation of lipid, resulting in the accumulation of sphingomyelin within lysosomes in a macrophage monocyte phagocyte lineage. Affected cells become enlarged, sometimes up to 90 micrometer in diameter, secondary to the distension of lysosomes with sphingomyelin and cholesterol. Histology shows that lipid-laden macrophages eat the marrow and see blue histocytes on pathology. Numerous small vacuoles of relatively uniform size are created, giving the cytoplasm a foamy appearance. The mechanisms of cholesterol trafficking in normal cells. The LDL-derived cholesterol enters cells via endocytosis by the LDL receptor and is then digested within the late endosomes and lysosomes. From there, it will bind to NPZ1 located in the membranes, then be transported to the ER and Golgi apparatus for recycling within the cell and ultimately to the plasma membrane where the majority of cellular cholesterol resides. After knowing all that information, how can we know now if an infant carries the said disorder? So here are the common signs and symptoms according to its type. For type A, they usually begin in the first few months of life and include abdominal swelling within 3 to 6 months, cherry red spot in the eye, having feeding difficulties, the loss of appetite, and the loss of early motor skills. Symptoms of type B, on the other hand, shows almost no brain and nervous system involvement in Niemann-Pick disease type B. Symptoms are usually milder and occur in late childhood adolescence, and the abdominal distension and repeated respiratory infections are common. Symptoms of type C. Type C commonly affects school-aged children and usually include dystonia or the difficulty in moving the limbs, splenomegaly, the enlargement of spleen, hepatomegaly, enlargement of liver, intellectual disability, learning difficulties or having dementia, jaundice at birth or shortly after birth. Another symptom is having seizures, being slurred or having irregular speech, the cataplexy or the sudden loss of muscle tone, which may lead to falls. Additionally, they can have tremors, vertical supranuclear gaze palsy or the trouble moving the eyes up and down, and ataxia, the steady gait, clumsiness, and walking problems. With the given symptoms, what are now its complications? Having Niemann-Pick disease can lead to risk factors such as blindness, infections, brain damage with mental retardation and delayed development of physical skills, deafness, and most probably death. What can be done now to prevent such risk? From a doctor's perspective, genetic testing can be used for diagnosis. This includes blood or bone marrow samples to be used for measuring the amount of acid sphingomyelinase or SM in white blood cells to diagnose Niemann-Pick diseases types A and B. These tests are not useful in identifying the carriers of the disease. Rather, it is used to identify those who carry the mutation but do not have the clinical disease. For these purposes, DNA tests are being indicated. Type C can be diagnosed through skin biopsy, where a sample of skin is taken to examine how the cells move and store cholesterol. Other tests employed includes bone marrow aspiration, where the technician will take a sample of the soft tissue that is inside the bones. While not a very sensitive method, it is typically used to perform for patients with NPC, where macrophages with abnormal cholesterol storage or foam cells can be detected in the bone marrow. A slit lamp examination of the eye, and liver biopsy. However, liver biopsy is not always required. So after being diagnosed, our number one concern now is the Niemann-Pick disease treatable? And to answer that, none of the types of Niemann-Pick disease can be cured completely. Treatments are being limited and thrive on supportive measures. Type A disease has no effective treatment currently. Enzyme replacement therapy, bone marrow transplantation, and gene therapy are being studied for type B disease. New drugs like miglustat have started to make appearance in the treatment of type C disease. Miglustat inhibits glucosylceramide synthase, an enzyme that takes part in the synthesis of glycosphingolipids whose accumulation occurs excessively in Niemann-Pick disease. For type C and D, frequent placed on healthy low cholesterol diet and cholesterol-lowering drugs are its prevention. There are also various treatment strategies that are adopted to improve the quality of life. Following are some of these treatments: supportive care through nutrition, medication such as giving miglustat drug to manage the neurological symptoms of the said disease. In a study comprising 92 patients of the disease, the drug has a positive impact on the neurological symptoms when taken for about 2 years. For physical therapy, patients with the disease have poor balance, gait, and coordination. As the disease progresses, the mobility becomes difficult. Hence, physical therapy is important to keep the patient mobile as long as possible. Antibiotics. Dysphagia may result in recurrent infection of lung due to fluid and food going into the lungs. Hence, giving antibiotics are prescribed to prevent the infection. Likewise, parents may also need to consider placement of a feeding tube or a gastrostomy tube for infants that has difficulty in eating. As such, organ transplant has been attempted, however, with limited success. Several other treatment strategies are under investigation in cell culture and animal models if NPC includes cholesterol mobilization, neurosteroid replacement, curcumin, and pregnant X receptor. Since Niemann-Pick does not have any cure and in some cases it becomes fatal, how do we stop Niemann-Pick then from spreading? There would no such way to prevent it because it is entirely hereditary. However, it can be early detected through DNA test and identifying the genetic defects in the DNA of many patients. Nevertheless, in my own opinion, Niemann-Pick can be avoided if partners or couples would take a DNA to know if both have the gene codes for the disorder and that it may help divert their position about having a family. And is there a natural way or remedy for Niemann-Pick disease? The answer would still be no. However, with proper nutrition, care, and support, the pain and seizures may decrease the patient's agony. It is, after all, the childhood in lifetime of many young children. This would be all for my discussion, and thank you for listening. And for the summary of the lesson, I have uploaded a video link from YouTube for more additional knowledge.
Niemann-Pick disease type A and type B, or NPDA and NPDB, are subtypes of acid sphingomyelinase or ASM deficiency. These are rare genetically inherited conditions characterized by the inability to break down a fat called sphingomyelin due to a deficiency of the enzyme acid sphingomyelinase. There's also Niemann-Pick disease type C, which is known to be caused by mutations in the genes NPC1 and NPC2, and is therefore considered to be distinct from types A and B. Sphingomyelin is a fat that's included in the membrane of many different cells. When cells become old or damaged, they are often phagocytized or eaten by macrophages, which are cells of the immune system. They contain organelles called lysosomes that are said to function as recycling centers because they break down large, potentially harmful substances to be reused by the body. They break down sphingomyelin by using an enzyme called acid sphingomyelinase, which is a product of the sphingomyelin phosphodiesterase 1 or SMPD1 gene. In Niemann-Pick disease types A and B, there's a mutation in the SMPD1 gene that causes a defect in the production of sphingomyelinase, leading to an inability to break down sphingomyelin. In NPDA, there's almost a complete absence of sphingomyelinase activity, while NPDB has some residual sphingomyelinase activity remaining. While the mechanism isn't completely understood, sphingomyelin primarily accumulates in the lysosomes of macrophages, which travel throughout the body and cause damage in multiple organs and tissues. The macrophages develop a characteristic lipid-laden appearance under microscopes and are called foam cells. Sphingomyelin can also build up in other cell types in the body, reflecting impaired intracellular recycling of membranes and damaged organelles and lysosomes due to sphingomyelinase deficiency. Signs and symptoms of NPDA present early in life and are usually life-threatening. These include enlargement of the liver and/or spleen, jaundice, feeding difficulties, and progressive loss of reflexes and muscle tone. Infants also often develop a cherry red spot in the eye that affects the macula, which corresponds with a decrease in central vision. This is thought to develop when excess material collects within the cells around the fovea, making them appear pale. Meanwhile, the fovea, which contains very few cells, remains its normal cherry red color. Macrophages accumulate in the lungs and cause interstitial lung disease that can progress to respiratory failure. This form of the disease is often fatal by the age of 3 years old. NPDB represents a less severe condition that typically doesn't include neurologic involvement, and manifestations can develop at any time in life. It may include any of the non-neurologic developments mentioned for NPDA and is generally characterized by progressive splenomegaly, which causes low serum platelet and white blood cell levels, high cholesterol, and declining lung function. Some patients fall in the spectrum between types A and B and are referred to as NPD type AB. Mutations in the SMPD1 gene are typically inherited in an autosomal recessive fashion, and while NPDA occurs more often in individuals of the Ashkenazi Jewish lineage, NPDB occurs in those of all ethnicities. Diagnosis includes a clinical examination in history, blood tests to detect sphingomyelinase activity in white blood cells, and genetic testing to evaluate the SMPD1 gene. Treatment of NPCA includes supportive therapy based on the symptoms that may include a feeding tube and medications to assist with sleeping. NPCB requires regular lab testing every 6 to 12 months and appropriate supportive treatment for whichever manifestations develop. Alright, as a quick recap. Niemann-Pick disease type A and type B are rare inherited conditions characterized by the inability to break down sphingomyelin due to a deficiency of the enzyme acid sphingomyelinase. In type A, the manifestations are typically fatal by the age of 3 years old, while type B is milder and can present at any time in life. Diagnosis includes an examination, blood tests, and genetic testing, while treatment consists of supportive therapy.
Niemann-Pick disease type C, or NPC, is a rare, genetically inherited condition caused by mutations in either the NPC1 or NPC2 genes. These mutations impair intracellular transport of cholesterol and other molecules, which causes progressive neurologic and developmental problems. Now, cholesterol reaches the cells packed in lipoproteins, which bind to low-density lipoprotein, or LDL receptors, on the cell membrane to get inside the cell. Then, cholesterol reaches the early endosome, which is an intracellular organelle that eventually matures into a late endosome and finally into a lysosome. Inside the lysosome, cholesterol is processed and recycled so that it can be incorporated into the cell membrane. To get out of the lysosome, first, cholesterol gets a little help from the NPC2 gene product, a protein that carries cholesterol up to the lysosomal membrane. And on this membrane, cholesterol is greeted by the NPC1 gene product, which is a glycoprotein that moves cholesterol out of the lysosome and into the cell. So with NPC1 or NPC2 mutations, intracellular cholesterol transport is impaired, so cholesterol accumulates inside lysosomes instead. Mutations can affect people of all ethnic backgrounds, and they're inherited in an autosomal recessive pattern, which means that an affected individual must have 2 copies of the mutated gene, one from each parent. Cholesterol buildup affects almost all cells, so it causes a variety of symptoms. The brain and bone marrow are often affected. The liver and spleen can be affected too, in which case they enlarge. Liver enlargement disrupts bile flow, causing bilirubin to accumulate in the blood. This leads to jaundice, or yellow pigmentation of the skin and whites of the eye. An enlarged spleen, on the other hand, may trap platelets, which causes easy bruising and bleeding issues. Finally, when this buildup occurs in macrophages, they develop a characteristic lipid-laden appearance under microscopy and are called foam cells. The most common symptoms are progressive neurologic symptoms, which occur in almost all affected individuals. With early infantile onset, there is usually low muscle tone and delay in developmental motor milestones, like lifting the head or crawling. Later, these children experience developmental regression. Infantile and childhood onset often begins with clumsiness and learning difficulties, and progresses to unsteady gait, difficulty swallowing, and slurred speech. Some children experience seizures or cataplexy, which is a sudden loss of muscle tone provoked by something perceived as amusing. With teenage or adult onset, there can be psychiatric symptoms and progressive cognitive impairment. Jaundice is more common in newborns, but rare in older children or adults. Late in the illness, patients lose the ability to walk, talk, and swallow, and respiratory failure is a frequent cause of death. Diagnosis of NPC is based on the clinical examination and history, and blood tests to detect biomarkers like bile acid metabolites and oxysterols. Finally, genetic analysis of the NPC1 and NPC2 genes confirms the diagnosis. Treatment involves supportive therapy, and in many countries, miglustat is used to slow neurological decline. Even though there is no cure for NPC yet, research is going strong, and several medications that target different steps in the pathology of NPC have shown promise in animal models of the disease and have progressed to clinical trials in humans. Alright, as a quick recap, Niemann-Pick disease type C is a rare, genetically inherited condition caused by mutations in the NPC1 or NPC2 genes, which impair intracellular cholesterol transport. This causes cholesterol to accumulate in lysosomes, resulting in brain, bone marrow, liver, spleen, and lung damage. Diagnosis includes blood tests and genetic sequencing, and treatment is mostly supportive.